Hey, good evening, everyone. This is the Atlanta Innovation Forum offering our webinar for this evening titled Is Telehealth and Virtual Care the New Normal? So welcome. We're really glad to have you here. We put together a terrific panel. People who have all in rapid fire speed had to morph their organizations or their own practices to bring telehealth into the picture and to continue to deliver for their patients and their customers. So they all have a really exciting story, and we're looking forward to sharing it with you this evening. Before we get going, just a couple housekeeping things. Atlanta Innovation Forum meets every month and is to provide members and guests with knowledge about all kinds of emerging, from 5G to fintech to smart cities to the emerging healthcare technologies. So we invite you to join us every month and stay tuned to our website for all the topics. So with that, the last housekeeping thing is we would love to have your questions at the end of the webinar. If you could please put them in the chat window, we will take them down and get back to them at the end of the program where we have a Q&A session. So with that, I would like to introduce first, before we get into our program, our top innovator of the month. Elizabeth Clubb is the founder and CEO of Care6. 10 years ago, she developed a passion for the longevity economy and is taking charge to create the world she wants to live in. So with this, Elizabeth, welcome and help us understand your exciting new business.
Thank you, Alicia. I am Elizabeth Clubb, and I am the founder and CEO of Care6. This is a picture of me with my father. This was a couple years ago, and I feel like I'm having a better hair day now. My father wanted to age in place in his home in New York, and my sisters and I wanted to support that decision. In addition to simply aging, my father also had Parkinson's disease. So I was fortunate that my sisters are both physicians in Connecticut, and they took care of his healthcare needs. But I took care of a bunch of other things, including financial caregiving. So we had a caregiver who lived with my dad, and he also had caregivers who came in throughout the week to help him with various errands and grocery shopping and things like that. And his solution for that was to give his caregivers his checkbook or a debit card. Some of these people he knew, some of these people he didn't know. And this caused him actually a great deal of fear, and it caused me a great deal of stress and anxiety. So the truth is that aging in place really is the new normal. 95% of older adults are aging in their own homes. And there's a lot of money that's spent in this space, and there really is no current solution to track that spending. Unfortunately, it leads to a lot of confusion, suspicion, stress, I can attest to, and in many cases, fraud. This is a problem that impacts a lot of people. There are about 56 million adults over 65 now. 10,000 people turn 65 every day, so that number is continuing to go up. There are about 50 million caregivers, the majority of which are family and friends, people like me, sons and daughters. There's about $150 billion spent just in this arena, and the most of it is on daily expenses of living. And unfortunately, elder fraud is about a $37 billion a year problem. So Care6 is a solution for that. It is a simple mobile-friendly platform linked to a Care6 account with connected debit cards. And those debit cards have controls on them for the amount that can be spent, where they can be spent, and the categories that it can be spent on. The platform provides transparency into the spending for the circle of care. Typically 4 to 6 people are involved in supporting an older adult aging in place. And it also provides real-time data so that if something is going wrong, it can be stopped immediately versus after the fact, which is what happens now. Our goal is to really connect the circle of care, to reduce stress and provide peace of mind for the number of people involved in this. It's to empower older adults to really get the support and the help that they need when they need it on their terms, and put them in control. And it's really to protect against fraud and financial abuse. So that's Care6. And what we're looking from or ask from you today is if you have friends or family members who are interested in being beta testers for early access to the product, we'd love to hear from you. And we're also looking for pilot partners for our launch. I appreciate your time. I look forward to hearing from you. And I'm going to turn it back to Alicia and this incredible panel. Thanks so much.
Great. Thank you so much, Elizabeth. We really appreciate your being here, and congratulations for being our top innovator. That's awesome. So now I would like to introduce our moderator this evening is Molly McCarthy, who's been in healthcare technology for more than 25 years. Her passion is uniting clinicians and technology for better patient outcomes. So Molly, join us, please.
Thank you, Alicia. It's great to be here and working with this fantastic panel. Before I introduce my colleagues, I do want to level set a little bit to help you as we talk about virtual health. I've been in technology for about 22 out of my 26 years in healthcare, and I've never seen a more rapid transition and transformation happen as it did during the past really 6 to 8 months with the COVID pandemic. That said, I do want to provide a little bit of background on when we talk about virtual health, really using that as an umbrella term and what that means. Specifically, what we'll focus on today is probably more around virtual visits and monitoring, et cetera. But it's very encompassing. And this slide actually came out of a study that was done by Deloitte and the American Telemedicine Association. Was published earlier this year, actually prior to COVID. It came out in January, but I think it's really impactful to take a look at this and to understand even prior to the pandemic, really where the market was in terms of thinking about virtual health. And I like to really go back to that particular study and think about the four C's about virtual health. One is continuity across the care continuum. Connectivity, so thinking about that connection, whether you're in the hospital, whether you're in the home, and also including both that synchronous video visit as well as that asynchronous communication that you might be having with your provider, for example, through a portal. The third one is that coordination, really coordinating that care. So critical. I've been, like I mentioned, in this business for quite a long time, and communication, collaboration, coordination is essential. And then really, again, thinking about that consumer and clinician access. So this is just some basics around virtual health and the taxonomy. You'll hear different words: virtual care, telemedicine, telehealth. And I think it's critical as we think about this area within healthcare, we really have those conversations of, what is the outcome you're trying to achieve? So with that, I'd love to introduce my panel here today. And they have fabulous experience. I've had the opportunity to talk with them over the past couple of weeks. We have Dr. Lacey Knight, who is the Chief Health Informatics Officer from Piedmont. We have Dr. Janelle Hooper from Access Hope. And then we have Nita Stella from Teladoc, who's actually one of Microsoft partners. So it's great to have Nita, you here. And I want to give them an opportunity to introduce themselves, because I'm sure I will not do them justice, and really talk about their interactions over the past few months around telehealth, telemedicine, and really when you think about that terminology, how do you define it within your institution? So Dr. Knight.
Hi, Molly, thanks for that introduction. I'm really thrilled to be here and talk about what this year has looked like. I think for everybody, this year has gone fast and slow and changed the time frame for so many different things. At Piedmont, we had a footprint in telehealth where we were usually using inpatient solutions to do video consultations with stroke physicians and stroke patients, and on the order of around 300 encounters or visits a month. And then when COVID hit, we knew that we needed to keep patients safe. We knew that we needed to keep doctors safe, and we still had patients that needed to be seen. So over the course of about 10 days, we went from essentially no outpatient visits to roughly everyone, launching that, and reached as high as about 10,000 visits per week. It started with our primary care offices, really took hold with that, and extended to many of our specialists, therapies, case managers, really everybody was involved in this. And this was true across the nation. I know that even specialties that you wouldn't think would be involved in telehealth have jumped in, like urologists. It's become a popular area for them to interact with patients. So it's been exciting, and I'm looking forward to seeing kind of what the new path is now that we've reached at least one degree of a steady state. But we're looking forward towards the future.
Great, thank you. Appreciate those comments. And is it primarily virtual visits, that the video visits that you saw the uptick in, and are you continuing that? We'll talk more about this, but I'm just, thinking about questions as they kind of come to my mind and what the audience might want to hear about.
Sure.
So curious.
So we had a variety of different approaches. So we launched video visits, we launched some scheduled phone visits, and we also launched e-visits or online visits that were asynchronous, as you referenced beforehand. That was part of our toolkit, if you will, and trying to fit the right type of visit to the right scenario was what we worked really hard at doing.
Great, thank you, appreciate that. Dr. Hooper, I would love to hear more about your journey, your path, and a little bit more about what you've seen over the past 6 months around telemedicine, telehealth, and how you define that space within your area.
Absolutely. Thank you so much for having me. And so with my practice, I own a pediatric mental health practice. And initially, even with opening a practice, I had to decide on which type of software to use. And telemedicine was a component in most of them. And at that time, it wasn't critical for my practice because the majority of my patients were in the community. But then I still received the extra addition to my practice just because. And with the beginning of this year, the shift has been unbelievable, from not just visits no longer in person, and have switched to a tele-based visit, either FaceTime, phone call, computer, but I've also seen a switch with the demographics that I'm seeing as well. So it was initially just patients, pediatric population dealing with a lot of anxiety, depression, ADHD. This has now branched off into adults. So I'm getting a lot more adults who are struggling with mental health concerns because of the COVID specifically. And I think personally that my specialty, mental health, is very unique because it did allow me to continue to see my patients. They were able to continue their continuity of care with me. I can still provide them with mental health treatment over the computer and still prescribe medications over the computer as well. So it was very, very convenient. Again, not just for the patients, but for their parents as well. And they feel the safety of a video appointment in their home, but also have the security of that too, and felt like they can still get the same care that they receive face to face. One other thing I want to point out is, the main disorder that I manage is anxiety. And I saw a huge shift with that as well. So either the patients became very anxious because of COVID and were not able to even do a video visit and requested to still come see me in person, or it was like, I'm home now, I'm with mom and dad, my anxiety is gone, like I'm great now. So it was good to even see those shifts as well. But it's interesting, the dynamics of all these disorders and how they were directly impacted through COVID. I definitely see a lot of my patients will adopt this new form of treatment. And I'm also seeing patients out of state. So I think tele will be a very critical component with Access Hope in the future.
Right. Yeah, that's great. I know that when I first started talking about virtual health to different systems, I would say on a regular basis was about five or 6 years ago. And I distinctly remember talking with some clinicians who said the patients were very interested in having that televisit, but the clinicians, the nurses, the physicians, the remote docking station came in. This actually was a NICU, and they put a sheet over it and they stuck it in the corner because they just weren't ready to, to move to that modality. However, I have seen telepsychiatry as one of the biggest areas over the years that's really had success. So it's great to hear that, and that you're able to continue helping those pediatric patients.
Yes.
And I'm biased because I, started my career in pediatrics and NICU. So thank you. So without further ado, Stella from Teladoc, it's great to have you with us today. And obviously you bring a little bit of a different perspective. I don't want to steal your thunder, but I know Teladoc recently had a big announcement in the marketplace, and just curious from your perspective what you've seen at Teladoc working with customers across the healthcare industry, provider, plan, et cetera.
Yeah, hi, this is Stella, and I'm VP of Product at Teladoc. And that's actually right, Molly. We've seen tremendous growth. For those who may not know, Teladoc is one of the first virtual care companies, telehealth companies to go public. We went public in 2015, so 5 years ago. And since then, we've had pretty high exponential growth. The industry is very different from where it was when Teladoc started a couple of decades ago to where it was when we went public to where it is now. And it's a sort of a perverse thing to say, but all of the stuff going on in the world today has really helped shine a light on the value of access and the value of convenience, and then ultimately being able to get to a high quality care provider that you trust in these times is of the utmost importance. So having services available for people to go to and have access to really has been a big boon. Teladoc Health has locations all around the world. We're the largest virtual care provider worldwide, not just nationally. We service over 12,000 clients, and last year alone, we did about 4,000 telehealth visits. But now between March and this year, that's significant, a significant higher number that we're going to be seeing this year. The way we see virtual care is it's more than just telemedicine. Teladoc has invested in making this about a continuum of virtual services, because virtual really is the front door and for many people and access to their healthcare, and can be that. Digital access can help facilitate the convenience, the availability, and they even frankly can help foster a better doctor-patient relationship. So we are investing heavily in sort of making sure that the services available are available longitudinally, going from urgent care all the way to complex care, to access to expert network all around the world. Similar to what Dr. Hooper was mentioning, we did see a really high, steep uptake of services that had a slow growth over the last few years, and then suddenly have skyrocketed, which is behavioral health. Behavioral health is an area that obviously was in high demand, and it continues to stay high. Another area that we saw a high uptake in is dermatology. A lot of people couldn't go in for specialized support or ongoing support. This was the perfect venue for them to be able to access care. So we see it happening. I think the beauty is it's no longer a question of what is telehealth or what is telemedicine, but more about where can it be actually applied more ubiquitously throughout the market.
Great, thank you. And you touched on a couple of points that is a nice lead into our next question around access to care. I know that I happened to be out in Montana back in June after a long drive, and was visiting with my in-laws, and they were talking about access to care, access to telemedicine where they live, but they don't have great broadband, and they actually cannot get service. So with digital technology, where do you see, that improved access to care? What have you seen over the past, not even just the past 6 months, but the past couple of years in terms of impacting, greater access to care, and then hopefully making that positive impact on outcomes and costs? And that makes me, think about the quadruple aim, quite frankly. How can we provide better quality care at lower cost and better patient experience? So just any thoughts? I'll start with you, Dr. Knight, around access to care and what you've seen both at Piedmont, and then I know you were previously up in Chicago at Northwestern.
Yeah, I think it's been very interesting. So, Northwestern and in Chicago, it's an extremely dense population, it's extremely dense number of hospitals. I mean, many hospitals and options. So getting to a hospital is not an issue. Getting to a doctor is not an issue. There are many options. But at Piedmont in Georgia, we're spread throughout the state, and we have many patients that sometimes travel, an hour and a half to 2 hours to see their physicians for inpatient appointments. So access is a real challenge. When we first launched our telehealth program, and I won't get too technical here, but kind of our initial solutions locked in a very high quality video that required some very fast broadband speeds. And so we were identifying some issues with some of the areas that don't have great broadband access, which was new for me coming from a big city, and something that we needed to address. So we ended up getting that addressed with lower broadband access, which has been great. And I even heard a story yesterday about a care provider that had been taking care of a patient that was using a wheelchair for access, relied upon medical transportation or really expensive cab fare to get to the doctor's office, but really a lot of challenges with the cost of transporting themselves, the logistics of transporting themselves. And the doc had, because of the COVID response, the doc had picked up using video visits as part of their care, had talked to the patient and just said, you know what, for a lot of the things that we're doing, negotiating what the right dose is, what side effects there are, we could probably do this on recurring video visits. And so it's a great story about access that, we couldn't have addressed sooner. And I think the other piece, it's not maybe addressed in our circles, but I know that some of the larger vendors for broadband access reduced costs for that to support this, not only the schools, but the legislative efforts around telehealth.
Right.
So that's been a big deal.
Yeah, that's a great point. And Dr. Hooper, would love to hear from you. I know that you're down in the Atlanta area as well. You talked a little bit about continuity of care, but just curious from an access perspective, what pros and cons that you've seen over the past 6 months, 8 months.
Sure. So definitely the pros have been, again, greater access for these children who are struggling with mental health concerns. And actually, when I first opened my practice, I drove to Athens to a pediatric clinic, and they set up an entire teleconference room for me to provide psychiatric care to their patients there, because there was no psychiatrist in that area, which is still unbelievable to know there are certain specialties that are just still missing in different areas. And that's, related to access and computer and technology and what, if there's any internet even there. So I already started seeing the wave of planting mental health providers in areas to provide that access and close that gap to care. And I see it also expanding in the local communities and even in schools, because I've done some televisits in the school setting as well, because a lot of kids have anxiety, depression, ADHD, and the school nurse is overwhelmed. And so even having the access to having a mental health provider come once a week to the school, even once a month, is so important for these kids, so they can stay in school and get their education and learn. And so, We can be placed in primary care settings, we can be placed in pediatric clinics, we can be placed in school settings, and also the home. You know,
Mhm.
I a lot of children who have developmental delays as well, and even getting them out of the home, maybe even into a car, driving to the practice is such a, you know, a chore, a task for the parent. So even getting a computer set up in their home where they can talk to me again and still receive care is ideal. So I see us being placed in all these different settings to close that gap with access to mental health care.
Great. That's really a great point, especially around, I mean, not so much today because not everyone is back in school, physically back in school, but you know, I have a lot of friends who are school nurses and just, you know, that's where they spend so much time, and the access to care right there is huge. Just, you know, and I'm all for more school nurses. So,
Yes.
Nita, I know that you talked a little bit about access to care earlier, but any additional points from your perspective with Teladoc that you've seen in terms of growth? But then also perhaps around outcomes, if you've looked at any of that data. If I know it's probably still early, but that's kind of the next frontier, which is here really. What when we think about virtual visits, what you know, and access to care, how does that impact our patient outcomes?
Yeah, I'll touch on one piece of access and I'll go back to outcomes in a second.
Sure.
One of the things at Teladoc that we've always held strong to is that we do have to make the care access to virtual care what the patient wants. So we do phone visits and video visits. We have a 24/7 manned call center that's taking in requests all the time, and still about 70% of our requests on our general medical side, which is the urgent care visits, come as phone visits. And what's important for us on that is that it's about making sure that we can connect the patient to the doctor, and make it easy for them to connect to the doctor and not make it an issue with bandwidth or comfort or video capabilities as the barrier. The other thing that we've noticed is our uptick on mobile demand is rising higher than it is on phone calls or calling to the call center and calling in or using the web. So people want it to be where they're at all times. So you don't have to be in your home to get a video or to get a visit. You can be somewhere where there's a better cell coverage, as an example. So access should not be limited by technology alone. And so we want to make sure it's available to everyone. The other thing on access is in our services, primarily B2B, but we also have a direct-to-consumer component. And it's just as much about awareness and engagement. And we have a saying within Teladoc is about surround sound engagement. It takes about 7 touch points for an individual before they commit to memory. So having the information that the patient has access to that service, has a service available to them, takes effort to remind them that they can access this care. So engagement is just as important as the availability of the technology. In terms of outcomes, Teladoc has published a lot of reports on our impact and outcomes. We've shown that direct correlation of cost avoidance of someone accessing virtual care and then ultimately making the right care decisions in terms of follow-up has been documented. So almost a $500 savings per visit every time they access virtual care. And then we're able to document that the completeness of the visit is over 95% of the time that patients don't need to seek additional care for that same issue. They might have referrals for other issues, but they're not having to repeat a visit because they were not able to get serviced through a virtual mechanism. So I think the outcomes and satisfaction and accessibility somewhat ultimately speak for themselves and are documentable.
Yeah, I mean, the outcomes and costs definitely important, but also that piece that I talked about, that everyone touched on, quite frankly, is just that patient experience. And the consumers wanting, the virtual visit, that virtual access to their care providers, like they have in so many other areas of their life, and really bringing healthcare to 2020. My next question, which all of you have touched on, but I just want to bring it to the forefront again, and that's really thinking about when we think about, and I'll just say the virtual visit, and I'll also throw in there, the communication, whether it's synchronous, live happening, or that asynchronous, it might happen, back and forth. I would love to hear from each of you where you've seen not only, the biggest uptick, obviously, Dr. Hooper, telepsychiatry, as I mentioned, I've seen it be successful for many years, but what areas, maybe Dr. Knight, from your institution, you've seen be successful, and then Nita, also from your perspective. I know that when we talked about this earlier, it was interesting to hear the differences of, the areas that you felt were successful, for example, primary care versus dermatology, et cetera. So I'd love to share with our audience today some of the different specialty areas that you've seen. And I know for me, going into different institutions, 4 or 5 years ago, I would go into different specialty areas, and they each had kind of their own strategy and solution. And so, thinking about more of that platform approach today and getting all those clinicians on the same page, has it worked? Dr. Knight, specifically at your facility, can you touch on the different specialty areas and how they're using it? And if it's been successful, I guess.
Yeah, so we had, a lot of this was driven based on partly patient demand.
Mm-hmm.
So depending on the specialty, you really can't get the treatment remotely. So for patients that had either some sort of a procedure done, or were evaluated for specific procedures, sometimes a lot of those were done in person.
Right.
But we did find that primary care had a lot of uptake. Early on, they had estimated that vast majority, 80, 90% might be of their treatment may be amenable to that. And one of the areas of focus for them were really some of the annual wellness screenings that they do for some of our older populations, that they figured out a way to manage those remotely. That's been a great success. They found that some of the urgent or last minute slots was a big success. So if, for example, it's 6:30 now, but if there was an appointment, or 6:30 where I am, if there was an appointment at 7, but my doctor's office was 45 minutes away, I couldn't get there in time, but I could get to a video visit in less than a half an hour. That was a big win. And then rheumatology was an area that we had a lot of involvement. Response to medications, follow-up of medication side effects when those were changing. And then one other big area were infectious illnesses.
Mm-hmm.
So COVID was one of those. When we had patients early on that were ill, knew they needed to be seen, trying to address the symptoms, we had some reach out to their primary care physicians. They were able to have a video visit, direct them to outpatient testing, direct them to emergency departments if they needed to be treated there. But in essence, keep them from entering really busy places where other patients were going to be. Also proved true for patients, a few patients that had kind of diarrheal illnesses, where, yes, it wouldn't be contagious and they could be seen in the office, but from a patient perspective, it's really uncomfortable to consider, needing to be close to a bathroom and then also needing to be in a car or in a waiting room and all these other types of places. So those are areas that we've found a lot of uptake, but we've surprisingly seen a lot of areas where the patients still want to be seen in person. So it's been mixed.
Mm-hmm.
And then Nita, I know that from your perspective, we talked a little bit about that asynchronous and synchronous communication. And if you want to touch on that a little bit more, as well as the video visits, just where you've seen success of each of those different components of virtual health.
Yeah, I think you said this earlier, which is important, is that each reason for visit and specialty actually has a different reason for how the virtual is enabled. So Dr. Knight mentioned that asynchronous in dermatology has been extremely successful, and frankly, our dermatologists only go asynchronous. They don't want to do direct visits because they want the ability or the luxury of being able to take the images, which are now superior coming off of someone's cell phone even, and zoom in and zoom out, and then provide a diagnosis at their own speed and time. So in our system, we actually note that a lot of the dermatologists are completing the visits in the middle of the night. They're getting off of clinic, and then they're just going through and looking at these images and providing really thorough response and diagnosis, frankly, more thorough than if they were on a video conference or video visit face-to-face with that patient. Alternatively, though, we've definitely seen a lot of successes of non-video, non-phone modality, such as asynchronous messaging with our behavioral health program. Patients take to it. They really like the ability of having some amount of anonymity. Sometimes they prefer than to switch to video, but behavioral health is a good modality to consider. But alternatively, there are some things you don't want to leave to an asynchronous or a chat format. We're very cautious about quality and ensuring the right clinical protocols are in place to provide a proper diagnosis. So some things shouldn't be done asynchronously. And we're very, so our clinical team is very aware of what should follow proper guidelines and what should be either a phone conversation or video conversation, so the physician can make an appropriate assessment for their diagnosis. So we take that very seriously as we're thinking about laying out the programs.
Yeah, that's a great point. That, I should have asked when we were talking about the different specialty areas. And I think Dr. Knight, you touched on it. Some specialty areas just don't lend themselves to video visits. And I know, one of the areas that I also want to touch on as we think about virtual health is really with the advent of the pandemic over the past so many months, the silver lining for technology, quite frankly, is that adoption was rapid, and kind of where we are now, it depends obviously where you are in the country, but whether or not you're having a surge and you're still using those virtual visits. But obviously, and I can say this as a consumer and Microsoft employee, technology is not perfect. It's really about people, process, and tech. I often claim user error myself. But as we think about virtual health and you think about where we've been, let's talk a little bit about some of the pain points and I guess some of the challenges around virtual health. And again, when I say that, talking about video visits, et cetera, or whatever you are doing at your facility. And my follow-up question is really going to be around, how can you address those moving forward? So who wants to start there?
I'll start, because mine's quick, actually. The number one pain point I run into is internet issues. So if the internet is ever choppy or down or not functioning, for example, today it was storming really bad out here, so I had some connection problems. There goes my appointment. So luckily, my patients are very flexible, and we can switch quickly to a phone call, which has never been an issue. So I like that option. Again, a lot of my patients are struggling with anxiety, so they would prefer sometimes even speaking over the telephone versus, having to look face to face at someone. So I had a unique patient who she had anxiety in front of the camera, so she could not do the virtual. and she has a history of asthma, so she didn't want to come into my practice. And I actually ended up meeting her at the park, you know, because again, you got to meet your patient's needs at least halfway, because the ultimate goal is for the continuum of care. So I think it's about being very flexible and, you know, able to kind of adjust to your patient's needs.
Good points.
I'll jump in and add a couple of learnings from the surge, the COVID surge, and Teladoc in general. I think it's been, like I said earlier, wonderful for this industry to be able to open everybody's eyes on how easy it is to access telehealth. But you're also seeing some level of provider practices and providers sort of questioning whether they're going to stay continuing in telehealth, because I think one of the things that people probably don't put a lot of thought into is you are then also opening up expectations. Expectations of availability, expectations of infrastructure support. The patient can't log in, who do they call if they need to look at their records? You know, is there somebody to support them? Are there doctors available? Are they available 24/7 and into the weekends? People, we always joke here that why do they suddenly feel like a 5-minute wait for a doctor to get online is too long when they've been able to wait for 2 hours in a waiting room?
Really?
But the expectations are now different. And so to be able to meet those expectations, the infrastructure, the support system, the quality control, and then frankly, physician training has to be there. And I think that's a whole new opportunity for learning for the healthcare system but I think that's something that people now have to start thinking about also, not just simply turning on FaceTime, but you know, being ready for all of those other needs.
Any thoughts from you, Dr. Knight?
Yeah, I think those are great points. I really like the story about meeting in the park too. I think that's pretty cool. So the only thing I would kind of add, we've talked about what the ramp up would be, and I thought I would at least use reference numbers that, not from Piedmont, but from I think what I recall our vendor telling us, roughly there's a 50-fold increase in the volume of telehealth visits over the course of a month.
Mm-hmm.
You know, so that means everything is in demand. So devices, webcams, headsets, computers that had access to these types of things, the bandwidth requirements, whatever software that we needed to do. You know, Piedmont's got thousands of doctors and thousands of other people that are trying to use this that weren't using it 10 days before, as I mentioned, and we have, you know, a few million patients that weren't doing this before. So the tech support was a big issue, but we had planned for it in our initial rollout. You know, we had offices that didn't have as many patients, and so we had front office and some back office clinical support performing tech support. You know, they were the trainer, they were the troubleshooter. They did all of these roles to support the process, and they also were kind of quality control, if you will.
Right.
I think one big thing that we haven't mentioned thus far that's important is that the shift in reimbursement and then the ability for the insurance waiver of patients' copays also helped accelerate this. So insurance companies made it easier for patients to move into the space, and they made it easier they reduced the barriers for the providers to adopt it as well, because those providers still had all of the fixed costs associated with brick and mortar practices.
Right. Yeah, and those are great points, and we could spend a whole other session, I think, on policy and reimbursement. Just one final question, as I'm, thinking about. I just read another report. When I'm up late at night, I pull out my virtual health reports. Mm-hmm. And this one was really thinking about the hospital of the future and really just care, next generation sites of care. So we think about the virtual visit, but then we also think about like health hubs and remote patient monitoring. We've talked a little bit about it in the inpatient facility, but as we think about the virtual visit in the home and the hospital of the future and giving care at home, what have you seen or explored around, incorporating devices into that virtual visit? And for example, sending a patient home with a pulse oximeter that they need to check their pulse ox every 4 hours. Post-COVID, I spoke with a friend who's in charge of the outpatient response at Memorial Sloan, and I asked him how they were doing that, and they said, well, they were checking, writing it down, calling it in, and providing that feedback the old-fashioned way. So I'm just curious to hear your thoughts on some of the technologies emerging that you've seen, both from your perspective, Nita, as well as Dr. Knight and Dr. Hooper. I don't know if you use any devices in the outpatient world for psychiatric.
Not offhand, I can't think of any, but I can just see just an overall, I guess, wave of technology and healthcare that I knew I must stay current on, and not for mental health treatment, but also for my patient population. Majority of my patients are teenagers, and so I need to know the current technology because
Right.
I need to know the language, the technology, everything, and where it's headed to, so I can stay abreast of what's going on.
Right.
Because that helps ultimately with treatment. So, I saw small cases of telepsych already in progress, and even down to like assessments. We're able to send assessments electronically. They can fill those out pre-appointment, get them back to the doctor. And you can at least look at those and you have an idea of what you're dealing with before the patient walks in. Because in the past, these were handwritten forms. They come in, fill these forms out, and you take 15 minutes to assess it. So even little, advantages that I've already seen like health are cutting down on the visits and making the appointment more effective.
So are you saying that we're going to see you doing TikTok videos to meet the needs of your patient population?
Yes, I'm all up to date on Snapchat, TikTok,
Okay.
like everything. I know it all. And if I don't, I have 4 boys, and my oldest 2 are teenagers. And so I'll come home, I'm like, what is this? What does this mean? What does this mean?
Yeah.
I'm like, oh, that's this. I'm like, okay, I'm current now.
So there you go. I mean, you're set.
Yes.
So I guess Anita and Dr. Knight, from your perspective, expanding that, the hospital of the future, the care at home, whatever it's called this week, and the incorporation of devices, is that something that you're seeing, talking about, strategizing about as we move forward, coming out of pandemic? The article that I was reading said 2040, but it's really talking about it's actually going to happen now. So would love any parting thoughts.
I mean, I'll add really quickly. I mean, Teladoc definitely sees that as an opportunity, and where the current is, and in addition to the future, as you know, we've in the process of a potential merger with a company that really invests heavily in not just remote monitoring, chronic care management, but really smart, intelligent, AI-based monitoring and follow-up. So it's not just devices and data, but it's creating a whole ecosystem of behavior change, smart nudges, smart notifications, smart reminders that really is going to change the industry. Historically, though, we've been hesitant with just saying any device is okay, because a lot of times the doctors would say that not all data is good data.
Right.
So really making sure it's the right type of data monitor that's useful for the care, not just simply because it's the new cool tool.
Right. Good point. And Dr. Knight, one last steady lightning round comment from you.
Sure. So we're doing a little bit. We've got some remote monitoring devices as it relates to heart failure monitoring. I may be a little bit more on the reserved edge about where this is going to go, because maybe the physician practice part of me. But I think there's a well-described use set. Weights, blood pressure monitoring, pulse oximetry, those types of things are out there. How we get those incorporated in practice, I think, is difficult. The whole wearable market is super exciting, super interesting, but frankly, it's a whole different data set that we don't even know what to do with it.
Right.
So if we collected it, we think we've got a lot of data in EHRs today. If we collect wearable data, every step Molly took the last month, what's significant, what's not, is going to rely upon AI and other tools to do that. So I think it's exciting. I think it's interesting. I think we'll all be doing something with it. Really making it a big part where it's virtual. I think we're going to always need to talk to people in person.
Right.
So yeah.
I'm with you. Yeah, high tech, high touch, and yeah, interesting. I was on a boat, and I got off the boat and said I walked so many steps, like 7,000 steps. So inaccuracy too. So with that, I would love to turn it back over to our wonderful host, Alicia. We're going to open it up for a quick poll, around telemedicine. Will you continue to use telemedicine once COVID is over? So would love to get feedback from the audience if you are going that route. And I guess for lack of better definition, I would consider this a virtual video visit. Well, good. I think you guys did a great job of convincing the audience that it's here to stay. So with that, Alicia, I would love to have you conclude here and just really want to thank our panelists today for their time, especially in the evening. I know everyone has tight schedules and appreciate it. So Alicia.
Great job, you guys. That was super interesting. And I think we have a really engaged audience because we have several questions that, people are dying to ask. So Addie, do you have those teed up for us?
Absolutely. Yes, we definitely have a couple of questions. So if we can bring Elizabeth Clubb back as well. We have some questions for her too.
So this is for all the panelists and Elizabeth.
And Elizabeth, correct. Yeah, so if they can come back on. So the first question I have actually, it's for Elizabeth, and someone's asking, what signs do you look for in or within the patient stage to engage a product like yours?
What signs?
Correct, yes, signs.
Is that the question?
On the patient.
Oh, well, what happens is anyone who's aging in their own home and needs any kind of care, it can be, they don't have to have Parkinson's or anything like that. It's just helping people get secure support when they need it. And it's really interesting what COVID has done because a lot of people are in social isolation. And so allowing people to safely get care and trust other people is our solution. So it's not necessarily just a healthcare sign, it's anything where people need help. It doesn't have to be an older adult, actually.
Awesome. So we have another question. So this person says that they've heard of a particular specialty physicians group that they've used telemedicine, and initially because of the outbreak, it went up, and then it kind of like came down significantly for in-person visits, obviously. So the question was like, if any of you have experienced the same thing, going up and down in regards to in-person visits once they became available.
Yeah, I can share that from a primary care perspective, for example, we had gotten as high as 80% of the visits were some sort of telehealth platform. They're now down to 10 to 15%. There isn't a lack of interest in us supporting it, but a great demand of patients to be seen in person at this point. But we're looking at what we can do to continue to increase those because we think it's going to be important for access in the future.
Through my experience, I am seeing a small number increase of inpatient visits, and I I've discovered that the reason behind that is my patients want human connection, human interaction. So they're booking these appointments in person with me to talk to me in person. I've noticed that. And because we're hitting like month 6 of social isolation. And I've connected the dots where it's I'm kind of stuck in my home. Who can I be allowed to go out and see? Well, I'll go see my doctor. So I'm seeing more inpatient visits, but it's not because of any restrictions or guidelines been lifted. It's like I need to talk to someone in person. So that's interesting.
I actually a couple weeks ago called my primary care nurse practitioner and said, I want to see a human. I don't want to do a virtual visit. So I understand that.
Mm-hmm.
So we have a couple of minutes and more questions. So the next question is, how are you integrating digital tools into your interactions with patients in between visits? And are you seeing reimbursements also catch up to the needs of providers in using these particular products to help deliver better care?
So I guess I can speak to the digital tools. We've got some things that have had for some time, and pretty good adoption at Piedmont, but things like our online patient portal, MyChart. So we've been using the messaging function back and forth. We deliver test results electronically to those patients. We're looking at some solutions that can help patients manage care plans, self-directed care plans, as well as mentioned earlier, connections with remote monitoring tools, scales, blood pressure cuffs, those types of things are what we're looking at today.
And I can just speak on reimbursement. I've just noticed that more of the insurance companies are accepting telemedicine as an actual visit and are trying to match the in-office reimbursements to accommodate patients ultimately.
And then the only other thing I could add is that in remote monitoring, often it's sold as an incremental benefit to employers or plan sponsors, and so they just pay a per monthly or per engaged fee for these tools, but then the other things are billed directly as a visit.
I'll just add something that we actually didn't touch on, but is kind of top of mind today, just around HealthBot and using HealthBots as really that front line just to help. We've done it a lot with COVID in terms of coronavirus self-checker. We started with CDC. We've done many across the U.S. But beyond that now, we was working with the American Nurses Association around a stress self-checker. So if you go to their well-being initiative, they have a 10-question HealthBot stress checker. And so that's another area in terms of virtual health where we're seeing a lot of uptake.
So this is the last question. We actually have had great engagement. The last question is, how has telehealth increased or decreased physician burnout, particularly for ambulatory physicians?
So I think it's actually decreased it. I think for the reasons that Dr. Hooper mentioned and Molly mentioned, where there's a more social aspect of coming in to see the physician for ambulatory visits. Sometimes that'll lengthen the appointments, and it'll actually make it a little bit harder for the physicians to stay on time. And when they're late after the first appointment and they've got 20 more patients to see, it adds a bit of a stressor. Whereas with the video visits, I've actually observed that the physicians feel a higher degree of stress to be on time for the visit, but they can more so predictably close within the time frame. I think for everybody on the call spends all day on video these days, but 15 minutes on video probably feels more like 45 minutes in person. So it's for many, it's a mental relief if they know the patients are going to get connected, because the visit's not as challenging as it might be with all the office logistics. That's been my experience.
That's been mine as well. If I open my schedule and the entire day is tele, there's almost like a sigh of relief that I can see my patients from home that entire day versus, going in for 1 or 2 patients in the office. So it's shifted kind of the stress, less anxiety with going inside the office, and again, like managing a full load versus understanding I'll meet with my patients face to face over the computer, is less stressful.
I mean, obviously we take a slightly different angle, but one of the things our doctors, some of our doctors do this full time. I mean, that's all they're doing is telehealth visits. Some patient satisfaction anecdotes that we get is the patients feel like the doctor's actually looking at them. They're having a visit versus looking off to the side, typing with the side of their head on a computer. So they appreciate that there's full attention given by the doctor, and it's easy for them to do that. And then the doctors on the telehealth doc side is they have no administrative burden. We manage all of that for them, and so there's a significant amount of savings and stress that's relieved from the doctor there.
Thank you. So I think that actually concludes the Q&A. Thank you very much to our panels. Alicia?
Yes, that was fantastic. Thank you guys. Super great panel. I just want to, really thank you and appreciate your time with us today. As I said earlier, the Atlanta Innovation Forum does this every month. Next month, we are sponsored by our Women's SIG, meaning that's our women's only group. So we endeavor to showcase an all-female panel. So our topic next month is sustainability. And there are a lot of effects of COVID that have actually, in many ways, benefited sustainability. So we're going to be looking at how to build a more sustainable future and where we'll be exploring the importance of sustainability in the new normal. So, come back. It's September 17th, same time, 6 p.m. And the last thing is I would just love to thank our sponsors, Right Point, Stone Resource Group, Carabiner, Stable Kernel, and Cox. So thank you all for a great night. It was very informative, and join us again next month.
Bye. Thanks, everybody.
Thank you.
Bye.
Oh,